Good afternoon, everyone. Thank you for joining us. For those of you who I haven't had the pleasure of meeting yet, I'm Tim Rutledge, President and CEO of Unity Health Toronto, and it is truly my pleasure to welcome you to the virtual edition of Powerhouse 2020. Since the first COVID-19 case in Ontario in late January, our world has changed very significantly. And how we provide care in hospitals has changed quite dramatically over the past 5 months. When the COVID-19 pandemic arrived, we had no option but to move quickly. And I'm proud to say that we certainly did that at St. Michael's and across Unity Health Toronto. For example, we planned and operationalized 2 COVID assessment centers in just over 1 week. The one at St. Michael's Hospital is in the Li Ka-shing building, right across the street from the hospital. There we provide COVID assessments for people with concerning symptoms, as well as for the worried well. We're providing COVID testing for hundreds of people every day. And the amazing St. Michael's Hospital COVID assessment clinic team has done outreach, providing testing to people in shelters and in long-term care homes. We've accelerated the opening of some of the floors in our new Peter Gilgan Tower to support the care of COVID-19 patients at St. Michael's Hospital. We ramped up our COVID testing from over 300 tests a week to over 2,000 to track the virus. We provided crucial necessities for our frontline workers like food, parking, and a safe place to sleep. We provided our patients with tablets so that they can connect with their loved ones who can no longer be by their sides in the hospital. And we've cared for the most vulnerable members of our community, particularly those experiencing homelessness. Our scientists have pivoted to work on more than 100 COVID-related research projects. We are at the global forefront of the efforts to end the pandemic. For example, Dr. Mohammed Kadura is developing an app that can measure a patient's COVID-19 symptoms without any direct contact. And Dr. Prabhat Jha is leading a survey to find out how many Canadians have developed antibodies to COVID-19. We could not have done any of this without the amazing community of donors who have generously supported our Courage Fund and our Power Fund, to the tune of $11.5 million and counting. I am deeply grateful to each and every donor who has stepped up when the need was so urgent. On behalf of our whole team, many, many thanks to all of you. And now it is my pleasure to introduce Colleen Johnson, Chair of the Unity Health Board of Directors. And just before Colleen takes over as our host this afternoon, I'd like to share a video about the many ways our researchers and healthcare workers have responded to COVID-19 with the efficiency, expertise, and compassion that we're accustomed to at St. Michael's Hospital.
Chinese officials are advising 11 million people at the center of an outbreak of
Health
the new virus
authorities are still working to identify the virus behind
in the city of Wuhan, where the outbreak began, patients now in isolation, all trains and planes out of
This morning, I've declared a state of emergency in the province of Ontario.
virus and controlled it and got rid of it for them. So we want to mimic that in people that haven't.
Thanks, Tim. Hi, everyone. As we gather today, we acknowledge the sacred land on which St. Michael's and Unity Health Toronto operate. It has been a site of human activity for 15,000 years. This land is the territory of the Huron, Wendat, and Petun nations, the Seneca, and most recently, the Mississaugas of the Credit First Nation. Today, the meeting place of Toronto is still home to many Indigenous people, and we are grateful to have the opportunity to work in the community on this territory. And before I introduce today's speaker, let me express the board's profound gratitude to Dr. Tim Rutledge and our teams at Unity Health, including St. Michael's Hospital. We thank you every day, but especially during this terrible crisis. You make us so darn proud. So I'm delighted to host this online edition of St. Michael's Powerhouse Speaking Series. Our guest speaker today is Dr. Mohammed Mamdani, our VP of Data Science and Advanced Analytics. He's a rock star, as many of you know, a global pioneer in the use of artificial intelligence in healthcare. Mohammed is going to tell us how AI is changing the world at St. Michael's, making us smarter, better, and more efficient, and improving patient outcomes. He will also talk about how AI can help us recover faster from the COVID-19 crisis, and how AI can be used to predict and prevent future pandemics. Pretty powerful stuff. After Mohammed's presentation, St. Mike's Hospital Foundation board member Simon Chong will moderate a Q&A about AI and data analytics in healthcare. And now, please join me in welcoming the amazing Dr. Mohammed Mamdani.
Thank you so much, Colleen. It's an absolute pleasure to be here and to present on what I think is a fascinating area, especially during this time. So I'd like to talk about artificial intelligence, specifically at St. Michael's Hospital, and talk a little bit about its application in the era of COVID-19. I'm going to just flip over my slide. I guess some of you may ask, well, what is artificial intelligence? And some people may say, well, it's the fancy robot stuff. And other people may say, no, it's much simpler than that. Well, actually, if we look at the definitions that are out there, Google Dictionary, the source of all truth, the theory and development of computer systems able to perform tasks that normally require human intelligence, such as visual perception, speech recognition, decision-making, and even translation between languages. It seems almost magical. And of course, how do we do that? We use computers. But how do computers learn? How do they know what language we speak and how to speak it? Or how do they know how to converse with us or recognize patterns? Well, there's three things really that become really important, and there are many more. But first is data, lots and lots of data. The second is, where do we put that data? You have to have places to store it. And then, of course, how do you go through all that data really quickly in a timely way to get the information we need? Well, we have to have ability to process that data rapidly. So in practical terms, what does all this mean? You've probably heard of the data and analytics revolution. For those of you who shop, you go to stores and such, over the past decade or two, we've seen this e-retail business crop up, and groups like Amazon have radically changed how we shop. I imagine the vast majority of you have been on Amazon, and isn't it incredibly magical how it just knows what you want to buy next? It's almost scary. How does it do that? Well, it stores data. What it does is it says, I know who's shopping right now, and they look a lot like these 12 other people or these 2,000 other people, because I've also got patterns on millions of other people who shop as well. And I bet they would like the same thing. It mathematically computes that within seconds and gives you choices. So again, Amazon has radically shifted the retail sector. Of course, there's Uber that has radically shifted the taxi industry, for good or bad. And how have they shifted it? Through our smartphones. You can actually ask somebody who's driving in your direction to actually pick you up just through your smartphone, and it knows how to navigate and when to navigate. Of course, now we're getting into the area of self-driving cars. Self-driving cars are full of automation and artificial intelligence. How does that car know when to stop at a red light? Or it knows that you're going somewhere, so it needs to take a right turn at this stop sign, but it can't do it right now because there's a person crossing the road. Well, it has all sorts of data coming in from LiDAR, radar, GPS. It listens to voice. It does so many things within milliseconds to make those decisions quickly and to get you where you want to go. It's magic. Then, of course, the largest hotel chain in the world is not Marriott, it's Airbnb. Again, that's on your smartphone. And again, it magically knows the types of places that you may like best. And it presents those to you in a very sophisticated way. So truly revolutionary. Technology and artificial intelligence has really changed society and how we do things. But it's not all good news. There are a lot of failures that we can learn from in data science and artificial intelligence. There are many examples. I don't know if many of you have dealt with chatbots. So when you go and do online shopping, sometimes you'll want to ask about a product. You may not be talking to a human. You may actually be talking to an artificial intelligence chatbot. Basically, these chatbots are created to have conversations with you. There's an infamous example from several years ago where Microsoft introduced a chat box called Tay into the Twitter universe. And within 16 hours, people on Twitter successfully taught it to be quite racist and misogynistic. It's rather unfortunate. And Microsoft had to quickly pull Tay from the public environment just because of all that corruption. AI was basically learning what you teach it, and it learns to be racist and misogynistic. Then, of course, there's the famous IBM Watson. You may have heard of this, where basically the thought here is very simple. We have a supercomputer, we have artificial intelligence. What we will do is we will feed it lots and lots of studies that are published in prestigious journals, studies that are done in very pristine environments, ideal environments, studies that reflect results for a population. And so these are studies, for example, that study 1,000 patients who have a certain type of cancer. And then they say, for that 1,000 patients, this may be the right answer. Well, Mr. Jones, if I'm looking at you, you're not the 1,000 patients. You're unique in your very own way. And can you really, really tease that uniqueness out from a sample of 1,000 people? It's hard to do. So, of course, they have implemented this in a couple of places, and they haven't done really well. And part of the reason why is because a lot of times the IBM Watson AI algorithm will give suggestions that don't make any clinical sense, that are not that relevant. Sometimes it gets it right, but not to the level that clinicians would expect. So it's largely not really gone very far, unfortunately. The last thing I'll touch on is this ability for AI to recognize patterns. And one of the areas is diabetic retinopathy. So this is eye disease in patients with diabetes, and this can lead to blindness. So you can imagine waiting to see an eye specialist, waiting to get that test, and seeing if you're going to go blind, or not even doing that test at all. Google actually created this incredible algorithm using very, very ideal, pristine images, not what you typically see in practice, but it performed really well to detect diabetic retinopathy in those images. So of course, the thought was, why don't we put this into practice? And they tried in Thailand. And unfortunately, it didn't go over that well. Because the way the artificial intelligence algorithms were trained were on very clean data. And when you go into the real world, the lighting's off. It's not that clean. There's a wait list. There's people rushing. It's a very, very non-ideal environment. And they had a lot of learnings as well. So I'll turn it over to Simon with this.
Yeah.
Why is it so hard?
Yeah. Good afternoon. It's Simon Chong here. So I get to ask all the some tough questions today for you, Doctor, and facilitate it for you as well. So I guess, as you mentioned there, other industries have adopted and applied AI into healthcare. We know the technology exists. As you've mentioned, AI models learn via having masses of data. So why is the healthcare industry, Canadian networks, US systems, why are we behind in terms of application and adoption?
Yeah, it's a good question. And some people will say healthcare is too complicated. And I would argue so is driving a car. So are a lot of things that are very complicated. But there's lots of arguments for all of these. So to the audience, I would say if you had to pick one of these, which one would it be? And I think you're all probably guessing the answer. If you picked D, you're probably right. Because again, with A, the argument healthcare is much too complicated. We've tackled a lot of complicated things. We do it every day in our lives. Healthcare isn't ready yet to embrace AI. In fact, there's a survey that was done, a few surveys now, that have actually asked healthcare executives, are you ready? And the overwhelming response is, yes, we are. We don't have enough data in healthcare for AI. Healthcare is among the most data-rich sectors out there. We have lots of data. It's how we leverage that data. And I would argue the real reason is that we have trouble bridging AI research conducted in ideal environments with the messy world of healthcare. Thank you, Simon. So at St. Michael's, we actually wanted to step back and learn from all the challenges. Why has AI failed in the past? How do we build a better system? And we've done it, I think, in a unique way. We've built the most advanced hospital-based applied artificial intelligence program in Canada. And I think it's safe to say the largest, among the largest in the world, for sure. We've had a $15 million investment, and it's thanks to generous donors like yourself. We received $10 million from the Li Ka-shing Foundation several years ago, with another $5 million that St. Michael's had committed. And the first thing that we wanted to do was fix our data environment, because we fully realize you can't have artificial intelligence if you don't have reasonable data to work with. We spent 3.5 years working with IBM, not their way, our way, to really say this is what we need as data scientists, not what IT people need. This is what data scientists needs to work with clinicians. So we have a fairly unique enterprise data warehouse that was built for AI, really. We brought in deep learning servers, a lot of compute power. We brought in tools that data scientists want to work with. R, Python, TensorFlow, PyTorch. We couldn't find any natural language processing tools that we like, so we created our own to actually look through text notes and pull out words that are of interest. And of course, then we hired a pretty good data science team. We have a crazy process around hiring people that is absolutely rigorous, and happy to chat about that if anybody has any questions around it. But we're also very fortunate to have donors like Patricia and Lou Odette and the Family Foundation, who generously donated so we could actually bring in students and bring in incredibly top talent to help us. Of course, a good part of this is around collaborations. And we were very, very conscious that we really can't do this on our own. We really need to be able to talk to other groups who really excel at this. The Vector Institute, the University of Toronto, which we're very closely linked to, Stanford, MIT, Google, Microsoft. These are just a few folks, and I'm going to comment on other collaborations in just a bit. But basically what that's led us to do is to be able to create really, really neat things. But how have we done it? Because what people typically do is they say, all right, we're going to create a good research program, and we're going to create these ideal circumstances. We just chatted about how maybe that's not the best thing to do if you want application. So this ideal research environment often creates these tools that really don't translate to an applied environment. We then quickly looked and said, we got a great team, we've got great infrastructure, we built this, but you know what? There's a hospital here. And in that hospital is the magic of chaos, is the magic of disarray, because we don't know when that next trauma case is going to come in. We have one of the country's best hospitals around trauma, critical care, I would argue among the best in the world. All that messiness is there, the real life. In fact, if we bring these two together, we have a living lab, don't we? And it's surprising how most groups around the world haven't really figured that out quite yet. But we wanted to develop our program with this in mind, with the intention to bring this real world to the ideal research setting and combine the two. Our model is very simple. we actually have this incredible team of data scientists, but they don't get to ask the questions. Instead, we go to the actual environment, people who see patients every day, who manage the operations every day, and ask them, what are the questions you have? Because you're much better at understanding the issues than we are. They bring the questions to us, they fully engage with us, work with us on a very regular basis to come up with our solutions. And in fact, I'm going to go through some examples, but I thought, well, what better opportunity than to actually bring in one of our internists, Dr. Amol Burma, who is an incredible internist, very bright, incredibly modest. So I'll say he's very well trained, Rhodes Scholar. I can't think of anyone better, has led our initiative around a very critical issue to internists. How do we predict who's going to die or go to the ICU? Amol?
Thanks so much, Mohammed, for the overly generous introduction, and thanks everyone for the opportunity to speak about our work. So a couple of years ago, our internal medicine group asked our patients, their caregivers, the doctors and nurses who work on our unit, what is the most important thing that artificial intelligence could predict in hospital? And they uniformly told us death or critical illness. Can you tell us when we or our loved ones are going to become critically sick? What we know from our scientific literature is that the most common cause of unplanned transfer to an intensive care unit is clinicians like doctors and nurses not recognizing when a patient is about to become or is becoming really sick in front of their eyes and failing to rescue those patients. So we developed an artificial intelligence-based prediction tool with Mohammed's team that uses more than 800 inputs from the electronic medical record and runs in real time to provide alerts to clinicians about patients who are at risk of becoming seriously ill. These alerts occur 24 hours in advance of deterioration. So it's not like it's just telling you, something is immediately happening, but it gives you advanced notice and early warning that allows clinicians to intervene earlier and prevent bad outcomes. It's like having a guardian angel, right, to put it in the terms of St. Michael's Hospital, monitoring our electronic medical record and giving us early warning signals so that we can intervene earlier, prevent bad outcomes, and communicate better with our patients and their families about their risks of becoming critically ill. We compared this tool to our doctors and our nurses in over 4,000 cases, and we found that the tool is 20% more accurate than clinicians, and the tool is itself 98% accurate at predicting bad outcomes. In addition to the prediction tool, we developed a comprehensive clinical pathway so that the doctors and nurses know what to do when they receive a high alert signal. And this is a perfect example of what Mohammed is talking about, the magic of messiness. It's one thing to just create a tool. It's another thing to build a laboratory devoted to implementation with the frontline caregivers and the patients and the clinicians providing input on what should we do for these high-risk patients. So we've developed this comprehensive program that involves a state-of-the-art technology. It involves the healing touch, and it involves the voice of our patients and their caregivers. And we are deploying that tool this summer, making it the world's first artificial intelligence-based tool to be actively deployed and rigorously created and studied in a hospital to predict and reduce death. And we will be studying it over the next year to see how it actually is able to improve the care we provide for our patients. And importantly, related to COVID-19, the majority of our COVID-19 care happens on this unit. And so we'll hopefully also be able to improve the care we're providing to those patients.
Great, thank you so much, Amol. And I'd like to emphasize, it is the brilliant minds like Amol who come to our group and say, there's an issue here, and I want to work with your team to be able to help address this issue. And that's why we're able to get AI tools that not only work well, but are able to translate. Some other examples, and I won't give you too many, we have over 20 projects that we work on at any point in time. We've developed quite a few solutions here. Something that we hear from our emergency department folks, well, they actually came to us and said, here's our problem. We have a lot of patients coming to our emergency department. And on many days, we get way more than we'd expected. And on some days, we get less than we'd expected. But when we get a lot of patients, we're scrambling to get that additional nurse to see if physicians can extend an hour or two on their shift to make sure that we're covered well. But if we knew days in advance it would be so much better. So we said, okay, you know what? We can actually grab some data. Why don't we actually take a look at 3 years of historical data from our hospital? We'll grab weather data. So is there a snowstorm tomorrow night? We're going to grab city planning data. Are the Raptors playing at the Scotiabank Arena? Well, not these days, but at the end of the month. What does that mean in terms of marathons happening at Lakeshore Boulevard, for example, and affecting our volumes? And sure enough, we created a tool. And the emergency department leadership had said, this is exactly what we want to see. We're able to predict 3 to 7 days in advance how many patients will come to emergency department. So we can tell you, today's Thursday, we can tell you tomorrow from noon to 6, there'll be 82 patients in the emerge. 10 of them will have mental health issues. 12 of them will be high intensity cases, and the rest a little bit easier to manage. We can do this with between 94 to 96% accuracy. And this has helped us quite a bit to plan. And our emergency department leadership looks at this tool, we know, 5 to 6 times a day for planning purposes. Now, of course, this has been very appealing to other hospitals. We're not really positioned to scale, but we have been able to implement this at 4 other hospitals and are providing support at that end to get this tool out. Another example is around medical imaging. If we look at the use case of intracranial hemorrhage, so this is basically somebody bleeding in the brain. That's a pretty serious thing. Now, if we look at St. Michael's alone, just last year, we had about 630 patients who were sitting in our emergency department with a bleed in their brain. How do you know they have a bleed? Well, you do a scan. Typically, you do a CT scan. CT scan comes in, then a radiologist has to read it. How long does that take? Because this poor patient is bleeding in their brain. Well, what we learned is it takes over 3 hours for the radiologist to get to the scan, to look at it, to read it, to then confirm it. That's over 3 hours that patient is waiting. I think we can do better. So what we've created, and we've actually been testing this over the past several months, and we had approval now from our leadership to deploy this, so it will be deployed very soon now. We have a solution now that not just looks at an AI algorithm, but it creates a whole platform for medical imaging. So as soon as that CT scan is done, it goes to the artificial intelligence algorithm, and it actually reads that scan. So the AI algorithm can tell you, does this patient have an intracranial hemorrhage? If they do, what's the subtype of hemorrhage? And where is it located? It can do this with well over 90% accuracy. And it comes, it's actually quite well accepted by our clinicians because the performance is quite good. And it can do this within minutes. So we're estimating that when we actually implement this, it will automatically read and highlight for our radiologists where there are problem areas. So we can change turnaround time from over 3 hours for that patient waiting to less than 10 minutes. Of course, these are just some examples, and people talk about collaborations. We have been very, very focused on collaborations. For example, at St. Michael's Hospital, we started the DASH Collaborative, which is the Data Analytics for Sustaining Hospitals. Basically, every year we bring together over 15 hospitals in the Greater Toronto Area to talk about data, analytics, our experiences, what other people are doing, so we can all learn and share from each other. And I think it's fantastic. So this is still going on and was started here at St. Michael's. Toronto Hackathon, we've worked with MIT, Google, and Vector, as well as Microsoft. Last year, we brought in over 80 hackers, I guess you could say, in the Toronto area to work with data and come up with innovative, creative healthcare solutions. We established the CARE Collaborative. We reached out to our colleagues at Duke, Kaiser, NYU, University of Michigan, Hopkins, and a few other places to say, you know, we should probably meet, let's meet every 3 months and talk about really cutting edge ideas, what we're doing, how we can actually help our patients. And that's actually quite interesting and a great experience for us as well. And the last part I want to touch on in terms of collaboratives is we have a very strong collaboration in medical imaging. That whole idea of looking at bleeds in the brain. Well, we're collaborating with Stanford, with University of Pittsburgh, and the RSNA, the Radiological Society of North America, very actively on these sorts of activities. So I'm going to hand it back over to Simon.
Yeah, so round 2 of questions for you, Doctor. Round 2. So there was a recent KPMG study around AI adoption in healthcare, and it asked, you know, what are the top 3 barriers to adopting AI in healthcare? I mean, you've just gone through 3 absolutely tremendous applied AI use cases. And that's one of the themes I want for all of our audiences, how advanced you and the St. Mike's team are in terms of the application of AI into a clinical setting. But just going through that, what do you think the 3 barriers are in AI adoption in healthcare?
Yeah, it's a great question. So KPMG actually did a survey, and I'm going to cheat and look at their survey. And they raised a whole bunch of issues, and this is what people talk about. They talk about, well, we don't really have a lot of or enough skilled data scientists, and I would say that's probably true. Talent is really, really tough. Good talent is extremely tough to find. Hardware limitations, data and privacy.
But on that point, by the way, on the talent side, I mean, we find just in my private enterprise is, you're competing with huge technology companies that are paying absolutely enormous salaries for these PhDs and masters in machine learning and AI as well, right? So it's a very competitive market if you're a machine learning or an AI scientist right now.
Yes, it's really hard, especially for an inner city hospital to try and recruit such incredible talent who are making considerably more elsewhere.
But you know what, Doctor? Our ROI is better.
Right.
We're saving lives, not saving money, so it's a better ROI.
I agree. And I'll go through an example in just a bit where just a few weeks ago, we had somebody come to us and tell us, an incredibly talented lady who is making, and will be making actually soon, because she's already secured a job. She's in the field, who has many opportunities, way more than we could afford to pay her. But she wants to work with us because she believes in the mission. And I think that's really important for the people who work here. But yeah, other things that came up was a lack of desire to embrace AI. It's too complicated and cost. And if they had to highlight 3, and I'm not sure if the audience has done this, and I don't know what you think, audience, but the 3 that came up as the most challenging, as you have said, Simon, talented, skilled data scientists was right up there, as well as data and privacy concerns and cost. And fortunately, I'll say that we've been very, very fortunate to be able to attract really top-notch data scientists. One in particular, actually, just last year, flew over to, I believe it was Singapore, to collect a prize for an international competition that she had won in data science, who's part of our team. Data and privacy concerns, we actually designed, when we were developing our infrastructure, we actually designed a process to address data and privacy with AI in mind. So I think we've been covered quite well. And I'm surprised that I believe, to my knowledge, we're the only hospital in the country that has this process, because we've thought it through right from day one. And of course, last is cost. And this is something we all struggle with, but we are so grateful to the donors that enable us to do the work that we do, that we're in a fortunate position that has been less of an issue. Now, the promise of AI during pandemics. So getting back to this whole notion of COVID-19 and pandemics, and this is probably what you're wondering about, what can AI do? Well, there's a lot that AI can do. The unfortunate part is AI has to have data to learn on. And when there's something so new and fresh, it struggles to learn. But when there's enough data, it can rapidly learn it and be effective. So what are some of the things? Well, there are artificial intelligence systems that are being designed to sniff out signs of COVID outbreaks. So where are these outbreaks happening? What are the patterns like? Where and when is the next one going to happen? That's where AI could be useful. Medical imaging. Can we actually use scans, ultrasounds, x-rays to actually constantly look and see if patients got COVID-19? A lot of work is being done in that space. And of course, how can we actually use AI to identify treatments and vaccines? And in fact, some of the treatments that we hear about now, AI assisted finding them, because historically without AI, it would have taken much longer to get at these treatments and vaccines. Of course, what's needed to get there? I'm trying to be very practical. And if we focus in Toronto, I'm going to look really at the 30,000-foot level and say, globally, what do we need? Well, we actually need an understanding of what is happening where. How did we ever discover that in Wuhan, China, something was happening? Next time, maybe it might be in Rio de Janeiro. Maybe it may be in Warsaw. We don't know. There's an organization called Blue Dot that was born out of St. Michael's Hospital. It was the first group in the world to publish on COVID-19. And they actually did it through very interesting ways. They actually have lots of data. They have data on travel patterns. So from all the airlines, they've been able to secure all that data and figure out who's traveling where. They are able to then also look at search histories. So on Google, for example, people are looking for symptoms, Every 15 minutes, they're actually constantly looking for where are people actually searching these things, where are they located in the world. All of these data come in. They've looked at mosquito breeding patterns, all sorts of weird data to try and figure out what is happening globally. It's almost like a smoke detector to say we're constantly surveilling. And as soon as that smoke detector comes off, then we can alert everybody else and they can get their action together. Now, if we focus on Ontario, as you know, there is an initiative. The province is developing a new health data platform to help defeat COVID-19. And there is a joint ministers roundtable around this infrastructure. And I'm very fortunate to be part of that roundtable where we're strategizing around, we have all this population-based data in Ontario. We know who's gone to see their clinician, where people have gone for hospitalization, testing results at the provincial level for over 13 million people. That's very, very powerful. So we can very quickly then detect patterns and figure out what's happening where. Now, a blind spot to this platform, and this is what I've raised to the group, is hospital data. And our own Dr. Amol Burma, the very good-looking and eloquent gentleman that spoke earlier, he is heading up an initiative called Gemini. Gemini has now recently been funded for a few $1 million by CIHR, our national research entity funding body, that is actually given the green light to collect hospital data on about 30 hospitals in the province. They already have 17 and we're already going to ramp up to 14, but now they're looking at 30 hospitals to bring all of that data in one place. You can only imagine the power that we'll have. Because something that we struggle at St. Mike's is, fortunately, we haven't had as many cases as other people. And that's a good thing because I think we've been top-notch at management. But if you don't have enough data, you're not going to be able to do AI. With about 30 hospitals worth of data, there's a lot of promise there to do AI. So we're very excited about that. I want to now focus on St. Michael's. Our hospital, what are we doing and how are we going to be making a difference? A few months ago at Angel's Den, I talked about real-time data systems. And the incredible part to all this is being able to say who's doing what, when, where. And sometimes it's not about all the fancy schmancy algorithms. And I'll tell you about why this becomes important. The first part is many hospitals were struggling with, okay, well, how many COVID-19 patients do we have? Where are they located? Which ward, which floor? I need to know so I can manage them properly. And I'll tell you, it's not easy because by the time we get lab results, by the time this person communicates with that person, it's hours and hours and hours. So we were literally running on a delay of about a day to a day and a half before we had numbers on what was happening. And by the time we got our numbers, it was already outdated because the thing was moving so quickly. We are no different. All the hospitals were struggling with this. So very rapidly, within a week, we said, let's automate everything. So we created a real-time reporting system. So we knew exactly how many COVID-19 patients we have, how many patients are under investigation, where they're located, and smart alerts to be able to tell us what's happening where. If we're able to do this, we can report every minute, but leadership had thought if we could do this every hour, that would be really helpful. So we can actually keep an eye on thing and really act quickly if we need to. And that's really helped us quite a bit. So our team had created this because we thought data is available, it's real time, this will help us manage. The other thing that became really important to us at St. Michael's Hospital is being a voice for the voiceless. Our emergency department leader, Dr. Carolyn Schneider, who is an incredibly compassionate physician, had said, here's what I struggle with. We are seeing hundreds and hundreds of homeless people. And our heart goes out to them because they're in this really awkward position of having nowhere to go after they leave our hospital. And they're high risk because they could be transmitting. How do we actually understand who just came in yesterday versus the day before, which shelter they were at so they don't go back and infect a bunch of people at the shelter? Right now, my process, as Carolyn had explained to me, is I've got 4 different groups putting in information that I need that takes hours to do, and I can't remember everything, and I don't remember who came in when. It's a mess. And again, we are no different than any other hospital. Many hospitals struggle with this. In fact, we had a call with Providence Health in British Columbia who's struggling with this exact issue as well. So we said to Carolyn, it's not always about predicting things. It's about automation as well. So why don't we create a solution for you? And again, within a few days, we had a system that was up where all they needed to do was say, oh, this person came in. As soon as it knows that and it knows which shelter they're from, it automatically pulls in all the relevant data for Carolyn and her team to do their job. And it also has smart alerts to say, as soon as I see 2 patients within a 48-hour span from the same shelter, I'm going to trigger right away and tell you this is where they've come from. So we can we can identify the outbreaks. This has been a lifesaver. It's an automatic tracking tool that's saved a lot of time. It's reduced manual effort significantly, and we can identify these outbreaks very quickly. In fact, it's received quite a bit of attention from well beyond our hospital to then expand this so others can benefit as well. Some things that we're working with Stanford on right now in the RSNA is around detecting COVID-19 through medical imaging. And again, our strength is not so much the algorithm, sure, that we can develop, but it's the platform we've created that puts that into practice, not on ideal images, but on everyday, dirty, messy, real images with excellent performance. And of course, as Amol had alluded to, can we actually use our algorithm that predicts death and ICU transfer on COVID-19 patients? I think we can. And this is something else that we're looking at to say, if somebody has COVID-19, are they going to die? Or are they really at high risk for needing intensive care? And if they are, we need to be able to know who they are and act on them. Many of you are probably wondering about surgeries. And yes, there is a massive backlog in surgeries. We started thinking a little bit about this. It's no secret, there is no magic cure for this. There's no magic solution. We only have a set number of surgeons, a set number of operating rooms. There will be delays. So anyone waiting for surgery or other hospital procedures delayed by COVID-19 is probably going to need to be patient. But is there room for improvement? Studies suggest there are. And in fact, I think there are improvements in not just at our hospital, but in practically every hospital. And I think we can do better. So we're already starting to look at this issue, looking at things that what is driving some inefficiency. Maybe we could look at errors, which surgeons take longer, maybe certain procedures take longer, maybe we're not fitting into the right slots as best as we could. And there are actually artificial intelligence approaches to try and look at this. In fact, the University of Colorado Health System actually has already leveraged machine learning and has realized considerable savings and efficiency through using machine learning around surgical scheduling and smoothing. And this is something, again, that's of big interest to our OR leadership and that we're actively working with them on. So these are some of the things that we're talking about and working on, just to give you a sense of the more global activity through Blue Dot, the provincial activity through the Ontario initiative, and of course, more focus locally at St. Mike's and what we're doing here. I just want to end by saying that many people have this kind of notion that AI is going to basically rule humans and take over the universe and will just be relegated to nothingness. And I want to emphasize to you that that's not the vision we have. The vision we have is not an inhumane environment where we rely on machines for everything, because I think, quite frankly, that would be silly. The environment that we would like to see is an environment where artificial intelligence helps our doctors, helps our nurses, helps our administrators, helps our patients. And we would argue that we would like to see artificial intelligence making the workplace more human, not less. And it's with your support and help that we're able to move towards this vision. So thank you.
Thanks, Dr. Mamdani. That was a absolutely wonderful presentation. And I think myself and all of the audience will have learned a lot in terms of the power of AI and how it can be applied in a clinical setting. And I think, you know, just for the registrants, before we go into the Q&A, I think what was amazing was, you know, there's 3 amazing use cases there with ChartWatch, the ED volume forecasting, and AI imaging of, you know, an applied use case where you're having to deal with real-time data, integrate into different systems, running it through your platform, and having, you know, amazing clinical results from it as well, health care results. That's fantastic. You know, I think it's no small feat. I do believe St. Michael's and you and your team, Doctor, are the leader in applied AI, if not in Canada, certainly in North America. So there's a few questions here. So this is part 3, and then you're done, Doctor. We've got time for probably 3 questions here from some of the registrants and audience. Sarah says, are other hospitals developing AI solutions as well? How can other hospitals benefit from this work?
It's a great question. Thank you so much, Sarah. In fact, many have interest in this space. In fact, we have been personally talking with several, and I think it's okay to name them. Very good conversations with sick kids, for example, who are developing a program. The UHN, University Health Network, is very aggressively moving in this area. Providence out in BC, we've had numerous conversations with them, along with many others. Humber River is actually getting into this space as well. And I think the more people that do this, the better. I think what I worry, though, is that we have a very research-focused lens. And I think we need to have research. Research drives a lot of this AI. But what I really urge other hospitals to do is take the applied lens, where it's not just a pristine environment, it's not just another paper that gets published, but rather engage end users, build solutions that embrace messiness and dirtiness, because that is the world we live in. And that's the model that we're trying to then show to others. And it's not just here in Canada or in Toronto. We've had numerous conversations with groups worldwide, actually, who are very interested in this space.
Yeah, that's fantastic. That totally makes sense. This one's from Michael. How do you know if an AI solution is actually helping people? So I guess that gets into one of those technical terms around model explainability. And what other examples are there of AI solutions that haven't been very successful? You mentioned Watson there, but there's maybe some others too.
Yeah, there's actually quite a few where it hasn't been so successful. In fact, we have a few examples. And I'll be very transparent. We have probably, if I had to guess, about 25, 27 solutions offhand. We have discontinued 3 of them because they haven't performed as well as we had thought they would. And I'm not afraid to say that. Personally, I think roughly almost a 90% success rate is pretty good. But how do we know if they work or not? And this is, again, where I really struggle with a lot of people who try to implement these programs. We have to have a process where when you implement something, you're not off the hook. You have to look to see if it's making a difference. And in some cases, I would argue, you may even be harming patients. But if you're not looking or watching carefully, you're not going to know. So what this involves is a process where you say, I'm actually going to develop and co-develop these AI algorithms. I'm going to then implement these AI algorithms. And when I implement, I'm not going to implement right away. I'm going to have what's called a silent testing phase or a shadow trial phase, where I'm just observing to make sure everything's okay. And that can take, our ChartWatch shadow trial, for example, took about 6 months. That's a lot of testing before you even implement. Now we're ready to implement, but we're going to also watch for at least 6 months after we implement to see if we're making a difference. And if we're not, decommission it. Don't follow it. Because AI algorithms can fail or people can fail to use them. But whatever the reason, don't continue failure. But you have to recognize it.
And I guess the message there to your ending statements was also around keeping humans in the loop. You know, even though the models are self-learning, you still need a human in the loop. That's just part of AI as well, right?
Absolutely.
Final question from Paul. It's more of a social question than a sort of technical healthcare one. You know, I see this come up a lot in all industries and when we're investing. Is from Paul, he asks, you know, is AI eliminating low-skilled jobs?
It's a great question. I would argue that for certain low-skilled jobs, yes. I mean, I think the politically correct answer may be, well, no, I think the real answer is yes. But, you know, I don't know if that's a bad thing. Because I do believe that everyone should be really focused on how they can contribute to society in a meaningful way. And it gives us opportunity to upskill. So because some low-skilled jobs may no longer be there because AI has really taken over that function, can we retain our individuals to actually do more meaningful work, more skilled work? And I think that's going to be better for everybody. They will have better earning potential. They'll be able to do more useful things. We'll progress as a society because of it. So I would say short answer is yes, I do believe that AI will reduce some low-skilled jobs. But I think the bright side of that is it provides opportunities for us to engage in meaningful work.
That's great. Well, just to wrap up, thanks again so much, Dr. Mamdani. That was amazing. Amazing application of AI in a clinical setting. I'll hand back to Colleen Johnson, the chair of the board of Unity Health.
Wow. That was a fascinating introduction to the tremendous power of AI and data to transform healthcare. There's clearly enormous potential to fight disease and save lives. Thank you so much, Simon, for helping us address some of the many questions we have about the mind-boggling implications of these new technologies. Thank you to Dr. Burma for sharing your expertise on data analytics and healthcare. And I loved your reference to AI as our guardian angel. And thank you to Dr. Mamdani for shedding light on these important issues. Thanks to you and your team, St. Michael's is leading the way in advanced analytics and healthcare. And of course, I'd like to thank you all for attending our online Powerhouse event and for your incredible support of St. Michael's relentless efforts to tackle our toughest healthcare challenges. We couldn't do it without you. Please don't forget to stay tuned for details on the next edition of our Powerhouse 2020 exclusive speaker series, which we expect will take place in the fall. Thank you and have a great afternoon.